Okay, hey guys. So we jumped ahead to chapter 9. Um, Katie and I, your other instructor, decided it would be good to talk about assessments so that as we teach you the anatomy of the body, you can already know or have an idea how to assess that part of the body. So before I move any further, let me tell you that you're going to get your assessment sheets. These are your skill sheets. This is the hands-on portion. This is how you treat a patient, the steps we take to identify the issues or treat the issues. When you first start, these things are intimidating. They're scary. This we're going to talk about pretty quick. There's another video on my YouTube channel for those of you following, where I break it down a lot and simplify it even. So let's get started. If there's at any point, anytime that you have questions, you need to go over something further, you don't understand something, send me a message and we'll work through it. Okay. So let's get started here. So patient assessment. Um, we're going to start with a scene size up, and that is ensuring our scene's safe. So from the second tones drop and we head out to that call, we're listening to dispatch. We're taking the information. What time of day is it? What's the weather like? Where's the location at? Is it safe for us to even enter it? What type of call is it? So ensuring scene safe is priority number one. We've discussed your safety, your partners, and then your patient, right? So that's our first step. So then we want to determine the MOI or NOI, which is the mechanism of injury or the nature of illness. So mechanism of injury is what caused the injury. What mechanism caused that injury? Or nature of illness, once again, what's the nature, what caused the illness, or what's going on? Take standard precautions, BSI. So we always want to wear our gloves at a bare minimum. Sometimes, depending on the call, eye protection, gowns, face shields, N95, surgical mask, depending on what's going on. So PPE or BSI on every call. We want to determine the number of patients. How many patients do we have? Which ties into considering additional resources. So do I have the ability to treat the patients that I have with what I have available? Do I need to call fire? Do I need to call law enforcement? Do I need a second ambulance? Do I need hazmat? So that's the kind of stuff we're looking at. This falls under helicopters. Also, do I need to call an air unit in? Then we move on to our primary assessment, and we're going to form a general impression. So the general impression, what do I see? I walk in to a house and I see an 85-year-old woman laying on the floor, her walker on the ground beside her. My general impression, I have an 84-year-old female who was falling while using her walker. That's what I see. Assess level of responsiveness. So it's called AVPU, and we're going to break all this down here in a minute, but we're going to go up to that patient. Hey, can you hear me? Are you okay? And they're going to be either alert. They're going to respond to my voice, which is verbal, or they are going to need like a sternum rub or the pinch on the back of the arm. That's painful stimuli, or they're just unresponsive. So that is AVPU, which we'll talk about. Perform a rapid exam to identify life threats. We talked about this in chapter 6, the human body, I think, or maybe not, I'm not sure. ABCs, airway, breathing, circulation. Those are your big ones. We want to make sure our airway is open or patent. We want to make sure we are breathing adequately, which means good chest rise and fall. We're getting good breaths. And we want to make sure that circulation is good. So we're going to do cap refill, pulse rate, pulse quality. What's the skin look like? And then we want to update responding EMS units. So whoever's coming to help us, we need to let them know everything we find. History taking, once again, go to my YouTube. There's one on there that's called Ample or Sample, OPQRST. It's investigating the chief complaint and sample history. So, and I'll get into this in class, but if your patient is alert, they can tell you their chief complaint. They can tell you what's wrong. If your patient is not alert, or if they are unresponsive, then it is a chief, or it is a life threat. We have to find it ourselves because they're unable to tell us. But if they're able to talk to us, we can get a sample history. Sometimes we can use family or bystanders. So we'll break that down later, but it's signs and symptoms, allergies, medication, past pertinent history, last oral intake, and events leading up to. Second assessment, systematically assess the patient, assess vital signs. We do a reassessment. So we repeat primary assessment, reassess vital signs, reassess chief complaint, has it changed any? Recheck effectiveness of the treatment that we did, and identify and treat changes to the patient's condition. So patient assessment sequence provides framework so that you can safely size up any emergency scene. So before we rush in there to be superheroes, we need to make sure that we're safe. Conduct a primary assessment, obtain the patient's history, conduct a secondary assessment, and then conduct a reassessment of that patient. So we're going to do these reassessments to make sure that what we did up at the top there when we started treatment, we reassess to see if the patient's getting better because we're helping them, or if they're staying the same, or they're getting worse. So your scene size up. This is a general overview of incident and its surroundings. So we review dispatch information, location and incident, where are we at and what's going on. What did dispatch tell us? Because once again, remember what dispatch is telling us is what they've been told, and that's not always accurate. That's not your dispatch's fault. These callers are sometimes in a panic, and the way they word things or the way they tell dispatch things is not accurate. So we need to judge for ourselves as we're headed to that. We need to be thinking what could be going on, what can we be walking into, and when we get there, we definitely need to be paying attention to our surroundings. The main problem or type of incident, what was reported? Are we going for a normal lift assist, or are we going for a stab victim or a shot victim, or are we going for cardiac arrest, stroke, seizures? Main problem or type of incident, what that would go under, sorry. The number of people involved. So once again, how many patients do I have? This is important to know. Do I need further resources? Which is that next line, if you remember. Can I handle what's on scene with what I have in my one truck? Is this a rollover with ejection? Do I need to get the helicopter in the air so they can meet me there? Am I going to a possible domestic where someone could be violent or have weapons? Are there 4 people shot? Is it a car wreck with 6 people in the vehicle? Any of this can go into play. So if we can get a somewhat accurate number of people involved, it goes a long way because that allows us to get additional resources there. Once again, dispatch information, other factors that can affect time of day, day of the week, weather conditions. Mentally prepare for other situations you may find when you arrive on the scene. Sorry, my allergies are killing me. If you come across a medical emergency, contact dispatch using your two-way radio. We are always ready for a changing situation. Let's see, ensure scene safety. We've talked about this. Scan the scene. We want to have our head on a swivel. We talk to our partner as we're headed that way to that scene. When we arrive on that scene, we want to scan the area before we ever get out of the truck. If there is a hazard, we need to communicate that to anybody responding with us. Ensure the scene safety, so visual hazards. I'm just going to scoot through here because a lot of this we've already talked about. So invisible hazards, if I can talk tonight. So, electricity, biological hazards, hazardous material, poisonous fumes. So this is possible in our area. For those of you who are in class, we've got trains that run right here through town. who knows what they're carrying. Um, there's always semis hauling material. Any of this could be hazardous. We've got anhydrous tanks. If one of them pickups wrecked with an anhydrous tank and there's a small leak, that is a poisonous fume. That is a hazardous material that will kill you quick. So we need to be very cautious of the invisible hazards. Uh, if the scene's unsafe, keep people away until special trained teams arrive. So this is where we would be calling that hazmat team. And we need to step back. We need to stay back. Upwind, we need to get some traffic control in place. That's where we call law enforcement or fire department. You do only what you're trained to do. So you're not trained to go block traffic or signal traffic. You're not trained to go into that hazardous material area. You do what your scope of practice allows you to do. So determining the mechanism of injury or nature of illness, look for clues that may indicate how the accident happened. Ask patient, family members, or bystanders for additional information. Do not rule out any injury without conducting a secondary assessment. So look for clues that may indicate how an accident happened. So this is kind of going to be that mechanism of injury. Car wreck. Your patient was in the car that got hit and the doors caved in, 15 inches. Mechanism of injury is going to be blunt trauma. You took a solid hit to the side. Or one of my favorite ones to use, you're called to a man down in a driveway. You pull up and there is a ladder laying on the ground, a guy laying on a concrete slab, and about half of his Christmas lights are hung. The rest are just hanging there. Right there, my mechanism of injury in my mind is the ladder slipped, he fell, he hit his head. We have blunt trauma to, the head, the body, whatever it might be. So you just put those puzzle pieces together with what you find and what you see. So ask a patient, family members, or bystanders for additional information. If there's people around, talk to them. In this job, I can tell you that you stop being shy and you get really good at talking to anybody about anything. So we use everybody around us to get information when it's needed. Do not rule out any injuries without conducting a secondary assessment. So these things can pop up after we just kind of glance over. Some things are internal and don't show up immediately. We can't just be like, oh, yeah, you're good, go ahead. We need to do that full secondary assessment, and we need to constantly be reassessing these patients for any changes. Take standard precautions. Always have your gloves and a mask readily available. Gloves are the minimum, okay? Consider whether use of additional protection may be necessary. If they're coughing or sneezing or spitting all over the place, I'm going to go ahead and put glasses and a mask on. If blood is squirting, we're going to put glasses and a mask on. So it just depends on the situation. Wash your hands thoroughly after contact with the patient or contaminated material. Even if you wear your gloves, as soon as you get a chance, wash your hands. Okay. Determine the number of patients. We kind of talked about that already. So I'm going to move on. Consider additional resources. So we talked about that. Let's see. Propose of primary assessment, or the purpose, of the primary assessment is to identify life threats to patient. For general impression, note patient's sex and approximate age, determine whether the patient has experienced trauma or illness, determine patient's level of consciousness. So I'm going to back up there for a minute. If we arrive on scene and let's say that the old lady's laying on the ground and I walk up and I'm like, hey, what's going on? And she doesn't answer. I rub her sternum. Okay. I give her a good sternum rub and I might get a moan. At this point, it's my job to identify what's going on. That's where I'm going to start doing my vitals. That's where I'm going to do a full body assessment depending on the situation. A lot of times your vitals are a key, which we'll get into here in a little bit. The patient cannot tell me the chief complaint. They can't tell me what's wrong with them. At that point, I consider that a life threat, and I'm going to find the problem and treat it. My thing you'll hear me say in class is traumas are fun, medicals make the medic, because you actually have to start pulling away pieces of the puzzle to find the issue when it comes to those. So determining or identifying life threats is not always just as simple as, oh, they're bleeding out, or, oh, they're not breathing. It can be blood sugar. It can be a stroke, and they're not there. Nobody's home. There's a lot of things that can be. So it's not always the obvious life threats. You're going to hear life threats if their ABCs aren't working. It's a life threat. Sometimes we have to find those though. That patient's level of consciousness, again, AVPU, alert, verbal, painful, or unresponsive. Assess level of responsiveness, again, introduce yourself to be established, your reason for being at the scene, fact that you will be helping the patient's level of consciousness, introduce yourself, even if the patient appears to be unconscious. Talk to these people. Even if they're unconscious, I can tell you personally that seizures sometimes will wear people out to the point that they actually pass out when they're done, but they can still hear you while they're seizing. Sometimes they're just laying there with their eyes closed. I'm going to harp on this throughout the course, especially if you're in the classroom with me. We get down at their level. We talk to people like they're our family members, like they're our best friends. If it's a very traumatic event where it's really just, oh my God moment, the calmer that you can keep yourself, the calmer that person will be as well. So that introduction, hey, my name's Evan. I'm with EMS. I'm an advanced EMT. I'm here to help. Can you tell me what's going on today? If they're able to talk, that's excellent. If they're not, I'm still going to do that. I usually introduce my partner if I'm the first one to make contact. This is extremely important in building that rapport with your patients. Assess level of responsiveness. So we talked about AVPU. There it is. It's your alert, verbal, painful, unresponsive. So I really haven't went into detail there, but this is when we walk in the room, we get down to that patient's level. Hi, I'm Evan. If they communicate right back to me, they're alert. If I get no response and I have to sternum rub, or I have to touch them, or even if I have to pinch the back of their arm to get a response, that is a verbal response. Or sorry, that is a painful response. Verbal is when I talk to them. Alert is when I walk in and they follow me across the room. They know I'm there. So I should read that up. I'm sorry. Alert, they are alert. They're with it. They see you come in the room. They follow you across the room looking at you. Verbal is when I speak to them and they react. Painful is when I have to use a painful stimuli to get them to react to me. Unresponsive is I've spoke to them, I've touched them, I've pinched their arm, I've sternum rubbed them, and I got absolutely nothing out of them. That is unresponsive. So AVPU. Go ahead and write these down, take notes. We are going to use this from here on out in your career. From here on out, every single call, we're going to use everything we're talking about in this chapter. Perform a rapid exam. So identify life threats. Sequence is ABC unless suspected cardiac arrest, and then it's CAB. We'll talk about. Assess the airway. The patient is alert and able to answer questions. Airway is open. If they're talking to you, the airway is good. In an unconscious patient, you must open the airway. We're going to talk about that in chapter 7, which will be my next video, but there are steps to open that airway. inspect the airway for foreign body or secretions, clear the airway as needed. You may need to insert an airway adjunct, which we will talk about in chapter 7. So ABCs is airway, breathing, circulation. Is our airway open? Are they breathing good on their own? And C is circulation. Do we have good blood flow? Are we pink? Are we warm? Cap refill, is it less than 2 seconds? That's where you pinch your fingernail, it turns white and you open it and it turns red again. It should be 2 seconds or better. So if cardiac arrest is suspected, we need to do CAB or CAB. So circulation, airway, breathing. So circulation is we're doing chest compression, right? Or there's one other thing that this falls into, and that is if we're hemorrhaging. If we're bleeding out, we need to stop the bleeding, then worry about the airway, then worry about the breathing. Because airway, open airway, and breathing, getting oxygen through the body doesn't matter if our heart's not beating or if all the blood is just pouring out of us, right? So hemorrhaging or cardiac arrest, we worry about circulation first. Any other time, we're going to go airway, breathing, circulation. Perform a rapid exam, assess breathing. So assess rate and quality of breathing. If the patient is unconscious, use the look, listen, and feel approach. Check for foreign body objects and remove them. If the patient is not breathing, open the airway and perform rescue breathing. Once again, chapter 7, it'll be my very next video, probably done tomorrow. So we assess the rate and quality. So we want the rate. So we're going to count how many times they breathe in a minute. Yes, you can do that for 15 seconds times 4. You can do it for 30 seconds times 2. If the patient's unconscious, use look, listen, feel. So this one is exactly what this picture over here is showing. Let me get my little pointer here. There we go. So you notice she's down there, she's got her ear in line, and she's looking down the chest. So she's looking for chest rise and fall. She's listening for air movement, and she can also feel for air movement. I'm going to throw one more little wrench in there for you that it's not doing. So she's got doing a hip tilt chin lift, which is this maneuver, the way she's got her hands placed on his head. You can also slide this hand right down on the other side of his neck. And let's go ahead and check our pulse while we look, listen, and feel. Just something that I was taught. The book doesn't teach you that, but look, listen, and feel. You can do multiple things. Perform a rapid exam. Again, assess circulation. So the patient is unconscious. Let's check that carotid pulse. Always on the side that you are on. Don't reach across. If you're in my classroom, and Katie will tell you the same thing. This drives me insane. It's natural. Your hand just naturally fits right there. Don't do it. I'm going to get on you every time. Same side that you are on. So I'm standing here. I'm going to check that pulse right here. So if you'll find that you've got your throat, you've got your jawbone, there's a notch right up in there. You got to push. Don't just barely put your hands there. Go ahead and practice on yourself. Push up in there and you will feel that carotid pulse. That's where we check unresponsive patients. Okay. If the patient is conscious, we can assess that radial pulse. Now, if you remember, radial is on your radial side, your thumb side. That pulse is right through here. My watch is there, that makes it hard. So just kind of feel around. There's a little notch that your fingers should just fall into, and you'll be able to find that pulse. Once again, if you have a full minute, if it's not just life or death, let's go a whole minute. Let's count that pulse. If not, 15 seconds times 4, 30 seconds times 2, depending on the situation. So if it's cardiac arrest, we don't want to check that pulse for more than 10 seconds. It needs to be, no, 5 seconds is plenty to go. Nope, we don't have a pulse. Especially after you have practiced and you kind of learn how to find it quickly. Check patient for severe external bleeding. So we can do what's called a blood sweep. One, you can look down. If there's blood pouring out, we know there's a problem. Two, you can take your hands, gloved hands, and you just go like back of the head, shoulders, and you're gonna all the way down the body, and then down the arm, down the legs, and you go, okay, my gloves are clean, no blood. Or there's going to be times where it is very obvious. Look at the clothing. Is there blood on the clothing? Is there tears in the clothing? Read the scene, use some common sense. Assess patient skin color and temperature. Some people are paler than others, some are darker than others, but most of us can tell if there's good circulation. Yeah, they're nice pink, warm, and dry. That's what we want. If they're pale, cool, and clammy, that's a whole nother problem that we'll talk about later in the shock chapter. But we want to touch their skin. Is it cold? Okay, is it cold here, but warm here? Is it cold on the arms, but warm on the chest? So once we start finding that coldness, we kind of need to follow it a little bit, because that's going to tell us what's going on inside the body. Once again, we'll get into that. Here we go. We're checking that carotid pulse right there in that little gap. You notice they're on the same side that they're checking it. There's that radial. They went a little bit further down than I do. I'm up here closer to the wrist. While we're on the subject, never check your pulse with your thumb, because you can feel your own pulse in your thumb. So that lady or guy is using these two fingers. I am terrible about using these two fingers. Just how I've always done it. Don't know. So we don't want to perform that rapid exam. Description of the skin color. Pale, white, or light in color indicates decreased circulation to that part of the body or to all of the body. So if we are pale, okay, we've got a lack of circulation. This is a lot of times indication that we are going into shock. Our patient is shocky. And if we have flushed or red in color, indicates excess circulation to that part of the body. Before I move on, guys, get to know these. Pale means whitish, flush means red, blue, cyanotic. You're going to hear cyanotic from here on out in your career. Indicates lack of oxygen and a possible airway problem. So cyanotic is that blue purple color that people start to turn when they can't breathe. Yellow, also known as jaundice, indicates liver problems. And then you have normal. Update responding EMS units. So elements of report. So whether I'm teaching this like you're already on an ambulance, and I apologize. So you get on scene, the EMS is on its way. If you're not reporting to me in the truck or to the unit, whoever's coming, remember I told you, use your cell phone, put it on speaker, and be talking to dispatch the whole time. Hey, I've got a 27-year-old male. He was hit by a car crossing the road. He is alert, but in a lot of pain. He's able to answer all questions appropriately. He is breathing on his own, but he seems to be kind of pale and feels kind of cold. That right there tells us, because dispatch will turn around and go, hey, Unit 17, and tell us everything you just told him. That tells me that he was hit. He's alert right now, but he's going into shock. Very well could be trauma response because of broken bones, or he could have internal bleeding. Automatically, before I get on scene, I know what I'm looking for just by you relaying that information. Try to perform all 4 steps of primary assessment quickly as you make contact with the patient. So once again, if I'm an EMR, I show up on scene before the ambulance does. I want to approach, I want to get on their level. Hey, buddy, can you hear me? What's going on? Hopefully they can talk to me. They give me their information. I'm an EMR. I'm with EMS. I'm off duty. Is it okay if I help you? Yes. So then I'm going to do that assessment. Okay. Investigate chief complaint. Do not allow a conscious patient Don't let their comments distract you. The purpose of obtaining history is to gather a systematic amount of past history, conditions, illnesses, and injuries, determine events leading up to the present medical situation, determine signs and symptoms of the current condition. So, investigate chief complaint. What's going on? Why did you call 911? That is the chief complaint right there. Don't let patients' comments distract you. You make it through school, you're educated. Use your knowledge, use these steps that you are learning in your assessments to guide you. So we want to know, have you had any current surgeries? Have you ever had a heart attack? My favorite thing, because a lot of people want to tell you their history from 1945 on. My favorite one is I kind of lead them a little bit, which we're told not to do, but I'll flat ask them, do you have high blood pressure? Are you a diabetic? Did you ever have COVID? And have you ever had any cardiac history? Those are my main go-tos. If I'm in a hurry and they're trying to tell me a story, I just flat put it out there for them. Yes and no, that's all I need to know. We want to go ahead and find out what medications are on. What do you take this for? I'm not saying you have to learn all of your pharmaceutical stuff, but I'm saying that you're going to need to learn the basics, and you will over time. Determine events leading up to the present medical situation. So, once again, find out what they were doing that day, or the day before, or the day before that. A lot of times I'll ask them, have you done anything new in your life in the last week? Any new foods, any new medicines, any new activities? Determine signs and symptoms of the current condition. Once again, remember, a sign is something we can see, like a stop sign. We can see that. We can see an open wound. A symptom is something they tell us, and we can't actually see it. My stomach hurts is a symptom, okay? So we need to talk to them, get that information. Or if family's there and they're not communicating with us, the patient, we can be like, hey, have they complained about anything in the last couple of days? Oh yeah, they've said they didn't feel good for about 2 days now. Well, how did they say they felt? That's the kind of information we can get. Question the patient in clear and systematic manner. Learn relevant facts, including serious injuries, illness, and surgeries, prescription medications, over-the-counter medications, allergies to any medicines, foods, or seasonal allergies. This goes so fast. Are you allergic to anything? And what medications you're on? Do you have a list of your medications? Glance over it, hand that to us when we get there. I like to know, you can ask them, do you take blood thinners? Do you take blood pressure medication? Depression medication? A big one is any type of sex enhancement medication, or like performance medication, because that will also play a huge factor in this. Obtain sample history. Once again, if you want a little extra help, go to my YouTube channel. There's one on there on sample. It's ample or sample. Some books took the S out. Provide a framework to ask further questions of the patient. Ask your patient one question at a time. Listen carefully and use good eye contact. If the patient is conscious or senile, a family member or friend may be able to help you communicate this information with EMS personnel. Let's see if we want to. Okay. So sample. You don't have to memorize all that stuff. Please go watch my video, because I break it down and teach you how to learn it easier. But S is signs and symptoms. A is allergies. M is medications. P is pertinent past history. L is last oral take. And E is events leading up to. So what I tell my students, what I say is the easiest way to do this, and there's a lot of mnemonics we're going to use, but buy a 97-cent notebook at Walmart. All it is for these mnemonics in class. So we're going to write sample down the side. Okay, on page 1, we're going to write signs, allergies, medication, past pertinent history, last oral intake, events leading up to. Besides that, write out what it means to you in your words. Signs and symptoms mean blah, 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 blah. Allergies mean blah, 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 blah. Write it to where you understand it, because that's how you're going to learn it. That's how you're going to remember it. Buy that notebook and just every day do it 2 or 3 times throughout this course. While you're watching a video, sit there and do it and listen to me rattle. By doing that, you're engraving it in your brain, you're writing it, and the first time you go on a scene with an actual patient, I promise you, it's just going to roll out. You're going to be like, yes, oh yeah, sample. Hey, or signs and symptoms. Sorry, signs and symptoms. What signs and symptoms do I have? Allergies. Oh yeah, do you have any allergies? And it's just going to flow. That's just an exercise that really worked for me. That's how I got through my advanced school. Take those notes over and over and over in your words, not mine. Secondary assessment is done to assess non-life-threatening conditions. So why is that? Why are we doing non-life-threatening conditions? Sorry. Because we've already fixed the life-threatening positions. Felt like I was in. Sneeze. Excuse me. It's because we've already fixed them. When we found them up top there, when we first started and we found that ABCs, okay, we found those life-threatening positions, so we've already fixed them. So our secondary assessment is done to fix all the other stuff. And that can even be like broken bones. That can be, I mean, it's not just putting Band-Aids on things, but it's stuff that's not going to kill that person. Physical examination helps you locate and begin initial management, signs and symptoms of illness or injury. A sign is something about the patient you can see, we talked about, or feel for yourself. And a symptom is something they tell us. More mnemonics. I can't say that word for some reason. So I'm not going to sit here and pretend. DOTS is new to me. So DOTS, let's write it down in that notebook. That's deformities, open injuries, tenderness, and swelling. And then, so DCAP BTLS, which is this one over here, this is this big thing right here. We are going to use this a lot during our skills. We're going to use this a lot in real life. Once again, you've heard me say it time and time again, verbalize everything you do. So when we're doing our skills practice, when we're doing scenarios, I want you to say DCAP BTLS, and there will be times when me or Katie might go, okay, what's that mean? What's the A mean in DCAP BTLS? And it's fine if you go D, okay, that's what it means. So D is deformities, C is contusions or bruises, A is abrasions, P is punctures or penetrations, burns, tenderness, lacerations, swelling. It's part of the assessment, and when we get to that part, I'll explain in a little more why this is important. Please go buy a notebook. I'm just going to keep saying that because that's how you learn it. That's how we don't learn it to pass a test. We learn it and we practice it so that when the time comes, we know our stuff. Secondary assessment of the entire body. Okay. Can be done whether the patient is conscious or unconscious. Assessment of all unconscious, assume that all unconscious injured patients have spinal injuries. Stabilize the head and spine. So follow the drill. I don't have my book out. I don't even know what that drill is. So I will teach you in class. I think I've got a video on it on YouTube. There's only a couple small differences between the trauma assessment and a medical assessment. When I'm done with this, I'll go check my YouTube channel. If I haven't put a video up, I will, to make it super simple. So don't let these freak you out. There are differences, but they're not huge. Examine a specific area of the body. So performed on patients who have sustained non-significant mechanism of injury or on responsive medical patients. Based on chief complaint, may focus on a body part system. Medical complaint of chest pain, focus on cardiovascular system. Focus your attention on immediate problems. So, see where this is headed. So real quick, and I'll explain this in class. I'll make sure I have a video up for everybody. Trauma patients, we're going to do hands-on head to toe. Okay. Trauma patients, we do trauma naked and we get friendly with everybody. Medical patients, we are still assessing all body parts, but we're focusing on the problem. So if we come in and it's a medical call and I'm just going to go with abdominal pain, upset stomach for the last 3 days. So yes, I want to focus on the abdomen. I want to focus on their fluid intake, their fluid output, whether that be vomit, diarrhea, whatever. But at the same time, this is medical again. I'm going to get down to their level. I'm going to touch them. So one, I'm feeling their skin. I'm checking their temperature. I'm talking to them. So I'm checking their neurologic. I'm going to go ahead and listen to lungs and bowel sounds. So I'm also doing respiratory because I'm listening to those lungs. I'm listening to those the bowel movements, if you will, the GI tract. I can still cover most of the body parts and not do a full head to toe on medical. So trauma, we are getting very friendly. On medical, we're focusing on the problem. Okay. That is really the only big difference between trauma assessment and medical assessment. If you treat them both just as a patient assessment, and you remember those two simple things, trauma, I'm touching you, medical, I'm focusing on you. Okay, so that's how you're going to figure this out real simply. Sorry, I'm trying to catch up where I was. Perform on patients who have sustainment. Okay, we talked about that. Based on chief complaint, may focus on a body system, so that's medical. Immediate problem. Okay. I just didn't want to leave anything out. Assess vital signs. Respiration. Normal adult resting respiration is 12 to 20. Once again, important numbers. Count patient's breath for 1 minute. If you have a full minute, yes, awesome. So, yeah, I'll do that later. Check breathing rate and quality. So we want to count the rate. We want to know how many times they're breathing a minute. And quality means, is it good breath? Is the chest rising and falling adequately? Does it look like they are breathing without working at it? Pulse is another vital sign. Indicates speed and force of the heartbeat. I want to check how fast is the pulse. Is it strong? Is it weak? Is it regular? Is it irregular? Are you getting beat, 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 beat? That's an irregular pulse. I need to know that. So remember, we take a radial pulse from a conscious, awake patient. We take a carotid pulse from an unresponsive patient. So normal pulse rate for an adult is 60 to 100. Some people that varies. So you got these athletic adults, they could be 40 to 60 resting. Ask them. Once again, in this job, we're not shy. Hey, do you happen to know what's your pulse usually running? I can tell you right now, my wife, her pulse normally runs 80s to 100. That's normal for her. She feels great at that. My pulse runs about 84 to 89. I check it right now. That's where it's at. Determine rhythm and quality, which we talked about. Cap refill is that, like I said, we're going to pinch that fingernail. I don't know if you can see this or not. It's going to be white and then turn red. There you go. It should be less than 2 seconds. That is good cap refill. That means that I've got a good cycle of oxygenated blood going through my body. We talked about that. Blood pressure. Okay, systolic pressure is the force exerted on the walls of the arteries as the heart contracts. Diastolic pressure is arterial pressure during relaxation phase of the heart. So let's just stop right there. So when my heart beats, my arteries are going to pressure up. Okay, that blood is forcefully flowing through that artery and putting pressure on it. So my top number, my systolic number, is how much pressure is on my arteries during compression of my heart. The diastolic is when it goes and relaxes. That pressure, so that wave of blood has went through. So my systolic is the pressure on my artery, why everything's just at that split second of calm. So 120, 130 over 70 to 80 is textbook, I think, without looking at the book. Oh, hypertension exists when blood pressure remains greater than 130 over 90. Check blood pressure by palpation, feeling, or oscillation is listening. So we're going to practice blood pressures in class. We're going to do it like at the beginning of every class. That's what we're going to do. We're going to take blood pressures on each other. So that blood pressure cuff needs to be above the bend of your arm. I think it's the top 2/3 of your arm. You want, they've got indication or where the little hose comes off. You want it in line with your artery here, your AC vein. So if we're doing a palpation, that means we're not using a stethoscope. We're not listening. So what we're going to do, we're going to pump that cuff up, and we're actually going to feel for that pulse to return. So we're going to pump it up. The pulse is going to disappear. So your pulse stops. We're feeling as we release that valve, we're watching that gauge go down. And when it starts and we start getting our pulse, we can feel it. That's our systolic number. So it's going to be 115 over P is what we're going to put. That just tells us our systolic reading. Auscultation means we're listening. We're going to auscultate lung sounds. We're going to auscultate heart sounds. We're going to auscultate our blood pressure. And that's when we use that stethoscope. We pump it up. We lay that stethoscope on there, and we release that valve a little bit. And as soon as you start hearing that first dum, 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 that is our systolic. And when we stop hearing is our diastolic. We'll practice it. It's hard to just like imagine it, but we'll practice it. Skin conditions. You've heard me already say this multiple times. Check skin color, temperature, and moisture. We want warm, pink, dry. That's what we want. That's not what we always get. Normal body temperature is 98.6. Normal skin conditions are described as warm, pink, dry. Pupil sizes and reactive. So anybody right out of school, you're going to have a light pen that has the different sizes of pupils and the little numbers beside them. Examine each eye to detect signs of head injury, stroke, or drug overdoses. So we prop that eye open and we shine the light in and out, in and out. We make sure the eye or that pupil reacts. We want to note what size it was with and without that light. I'm not going to go into all the detail right now on what each one means, but it is important to see that. We want good reactivity. We really don't want slow. We don't want different sizes. We just want normal activity to light, or reactivity. Apologize. Determine whether pupils are equal sizes and they both react. Pupil sizes and reactivity. Pupils of unequal sizes can indicate stroke or injury to the brain. Pupils may remain constricted in a person who is taking narcotics. Dilated pupils indicate a relaxed or unconscious state. We'll talk more about this in person. Level of responsiveness. Observe and note any changes that occur between time of arrival and time you turn over patient care to higher level personnel. Use the AVPU. So AVPU is a vital sign. It's one of the first things we do when we get to the patient. But throughout our reassessments, if you remember, all of these vitals are going to be done in our reassessments also. Check that AVPU. Were they unresponsive when you got to them, but now they're starting to communicate? Or did you get nothing from them when you used painful stimuli, but now you're getting moans and groans? these are very important things because it tells us if what we're doing is helping or not. I think, okay, I'm gonna jump back here. I'm gonna add a couple assessments that's on here. Not that you're gonna be able to do this in the field, but if you're on a truck, pulse ox. We want to know what their oxygen level is, okay? So if we have a pulse ox, we want to do that. The other big one is a blood sugar. That is a vital sign. It is a super important vital sign because it can mimic a stroke. It can cause altered mental status. There's 1,000 things it can do. So blood sugar is a big vital sign that we need to add to our list here. If you need to continue to care for a patient, some parts of the patient assessment need to be repeated. This is that reassessment that I kind of just hit on. We're going to move through this pretty quick. So we want to check the patient for responsiveness and ABCs. So once again, we continue to do AVPU and we want to check those ABCs. What I was taught is when you're done assessing a patient, you reassess that patient. You have nothing better to do. We're going to assess. We're going to fix life threats. We're going to do our secondary and we're going to fix secondary injuries. And then we're going to reassess again. And we're going to continue to repeat that all the way to the hospital or until someone of higher level arrives. Continue to maintain an open airway and monitor breathing, pulse rate, and quality. We're going to continue to do vital signs and we need to be tracking those. We need to be comparing those vital signs. Okay, 10 minutes ago, he was this way. Now vital signs have dropped or blood pressure has improved or whatever it may be. We need to continue to compare those because it's telling us if we're doing good or we're doing nothing. Reassess chief complaint. Has it got better? Has it got worse? Effectiveness of the treatment is what we just talked about. Identify changes. Once again, better or worse. Reassess a stable patient, guys. Super important. Take notes. We're going to reassess a stable patient every 15 minutes. We have got to do a reassessment every 15 minutes. If the patient is unstable, we reassess every 5 minutes. If they are in danger of losing their life, that is an unstable patient. We repeat. Providing a handoff report. We kind of talked about reports in some other chapter, but we need to know when you hand off that patient to me or you hand off that patient to the ER, whatever it might be, age and sex of the patient. Sometimes we have to estimate it, but we can get pretty close. History of the incident. What happened? What caused this to happen? Patient's chief complaint. Why was 911 called? Or what was the life threat that we are trying to fix? Patient's level of responsiveness. Are they alert? Do they respond to you being there? Do they respond to verbal stimuli? Did I have to talk or yell at them to get their attention? Did they respond to painful stimuli? Did I have to sternum rub or pinch them? Or did they respond at all? Are they unresponsive? That's important. Throughout every assessment, did it change at all? How you found the patient? What position? Where were they? Was they on the ground? Was they on their stomach? Was they on their back? Were they curled up between the bathtub and the toilet? Status of vital signs. What were our beginning vitals and what are they now? Results of secondary patient assessment. Any pertinent medical conditions using the sample format, signs and symptoms, allergies, medication, past pertinent history, last oral intake and events leading up to, and any interventions provided and how the patient responded. So we all carry, either you can get on Amazon, you can buy those fancy little books that are just for EMS, or you can buy this, which is just a little 50-cent notebook. And I can put all my information during the call. I'm sitting there taking notes, or my partner's taking notes. I've handed it to firefighters before and said, hey, I need you to do this. And they take notes for me. So you don't have to remember 4 sets of vitals. You can also print them off your monitor if you're using your monitor. Point being, we need to keep track of everything we do, because reporting to us when we arrive or reporting to the hospital is extremely important, because when care starts, we always want it to move forward. We don't want the hospital to repeat everything we did back here, right? Or you don't want me to come on scene and repeat what you started. So if I get a good report, we just continue the care moving forward. No time lost, and it's best for us, it's best for the patient. So let's see. Okay. Patients can generally be classified into two categories. We talked about this. Those who have a sudden illness or those who have sustained a trauma. Medical calls make the medic. Traumas are fun. Traumas, there's obvious problem. It's right there in front of us. There are still some underlining things that might not be like visible, but we can kind of put the pieces together. Medical, those are the puzzles. Those are where we have to do everything in order, and we have to work through all these situations of what it could be and then start treating it. Those are fun. It takes experience to be good at it, and I'm not saying I am. I prefer traumas all day, but I'm saying traumas or medicals can be fun. Patient assessment sequence can be used to examine patients who have experienced illnesses, traumas, or both. So we are going to use a patient assessment, whether it's medical assessment or trauma assessment, on every single patient. Every patient, no matter how little the injury or illness is, we do the exact same thing every single time we roll out of this building. When examining medical patients, follow the basic assessment sequence. When caring for trauma patients, perform secondary assessment before taking medical history. So we want to treat injuries. In real life situations, we can do a lot of this simultaneously. I can be working on an injury and asking questions at the same time. Always avoid jumping to conclusions. So the summary, I'm not going to sit here and discover I talked too long. Go back through this, go through your book, take notes, go buy that notebook, please, like I told you to. We're going to hand out skill sheets that have it in order. And for the first few times, you can use that paper, okay? But like I said, buy a notebook, write it down, and then check it against that paper over and over and over, because it will become second nature. And when this really matters and you have a real life person in front of you, you'll be happy that you took the time to actually study it and learn it, instead of memorizing it. So which of the following steps may be performed during a scene size up, or might be performed during a scene size up? Assessing vital signs, using appropriate monitoring devices, forming a general impression of the patient, notifying dispatch to send fire personnel, or performing a full body scan. It is C, notifying dispatch to send fire personnel. Why is that? Because at the very bottom of our scene size up, it says additional resources. So we might be calling for additional resources. Let's see. The goal of the primary assessment is to quickly diagnose the patient's condition, determine needs to perform a full body assessment, determine number of patients, or identify and treat life threats. Okay, so primary assessment. We did our scene size up. So BSI, my scene safe, mechanism of injury or illness. How many patients do I have? Do I need additional resources? That's my scene size up. That next section is your primary assessment. And we want to identify life threats at this point. So at this point, we have made it to the patient. We have gotten down there with the patient. We want to identify and treat life threats. After performing a primary assessment and treating any immediate life threats, you should next determine priority of the patient care and transport, reassess the patient, check your intervention, or promptly transport patient to the hospital. I know you guys don't have your sheets yet, but determine the priority of the patient care and transport. So this A, B, C, I like to throw D. So airway, breathing, circulation. I like to throw a D in there where it's decision making. This is where I decide how I'm transporting that patient. Anyway, guys, that is your assessment chapter. please, please, please get on Redneck Medic, your YouTube, and watch my assessment videos. I think there's 2 or 3 of them. I'm fixing to go check. It will break it down a lot simpler without all of these slides. Okay, it's like a 10-minute video. Anyway, I will catch you on the next one. My next one's chapter 7, and it is airway.